Uh, Good evening, everyone. Today's discussion of topic is hypoglycemia. What is hypoglycemia? In 1930s, it is defined in the People's Triad, where the triad of hypoglycemia will be there, and signs and symptoms of hypoglycemia and the recoveryness of hypoglycemia will be there. But recently, International Hypoglycemia Study Group redefined it and it classified into three types: hypoglycemia alert value, and clinically significant hypoglycemia, and severe hypoglycemia. Hypoglycemia alert value, it should be blood glucose level should be around less than 70 milligrams per dl, and it can be treated with fast acting carbohydrates, oral carbohydrates. When clinically significant hypoglycemia, where the patient will be having blood glucose levels is 54 milligrams per dl, this is a serious and potential consequences will be there, and dextrose or glucagon can be given. Here severe hypoglycemia, where there is no value for blood glucose value, so here you can give the patient dextrose and glucagon, and the patient will be having severe cognitive dysfunctions, and sometimes seizures also will be there. So body response when the hypoglycemia is there, immediately when the blood glucose levels comes to 80 to 90 milligrams, our pancreas decreases the insulin production, and glucagon levels will be increased. So when the blood glucose levels comes to 80 to 90 milligrams, in the liver there is a glucagon production will be there. There is a glycogenolysis and gluconeogenesis. These two processes will occur, and generation of the blood glucose will be there. So another mechanism this body responses is when there is a adrenal hormones, brain is constant glucose supply by limiting the use of the non-essential tissues, where the blood glucose levels will be decreases, and it will be used for the brain. It is the response by the adrenal hormones. Next is counter-regulatory mechanisms. What is the counter-regulatory responses? There are the two in our body. There are the two important counter-regulatory responses will be there. One is adrenal gland, second one is the PNS, peripheral nervous system. And adrenal glands, there they produces the epinephrine, and it acts on the muscles, and there decreases the glucose use, and kidneys by decrease the glucose clearance. So there it will increases the blood glucose levels. In peripheral nervous system, there increases the acetylcholine. So both this epinephrine and acetylcholine can trigger the autonomic responses to act the patient with low glucose levels. So they will autonomic responses like sweatings, tremors, and all those things will when the patient is having the low glucose, alert. These are the alert mechanisms. Then releases. Next is cortisol and growth hormone decreases the consumption of glucose by non-essential tissue. There increases the blood glucose levels. Next is what are the signs and symptoms of hypoglycemia? There is mainly two types of signs and symptoms will be there. One is symptoms will be autonomic symptoms and neuroglycopenic symptoms. Autonomic symptoms already I have been discussed previously. One is acetylcholine and epinephrine. This will cause the tremors and diaphoresis and palpitations and anxiety pallor. When these are the symptoms, when the patient is on beta blockers, they can mask the autonomic symptoms. So in these autonomic symptoms, when the patient is on beta blockers, it masks, and these autonomic symptoms will not be appear in the patient is on beta blocker. Second one is neuroglycopenic. Due to the lack of glucose in the CNS, patient will be having cognitive impairment, confusion, behavioral changes, anger, irritability, blurred vision, headache, seizures, and loss of consciousness, coma, and death will be there. Sometimes hypoglycemia associated with MI, stroke, CV death, and QT prolongation will be there, dementias will be there, and cognitive impairment also will be there in severe hypoglycemia. So what factors contribute to the hypoglycemia? One is oral anti-diabetic drugs, oral hypoglycemic agents, in that sulfonylureas and meglitinides, rapagliflozin and adagliflozin. When given these drugs as a monotherapy, there is a chances of hypoglycemia is 2 to 8%. When given in combination therapy, 4 to 8 fold increase in the hypoglycemia. Next is aspirin, warfarin, allopurinol, probenecid. These are also will cause hypoglycemia. Next is insulins. Basically insulins, NPH, neutral proton H gun insulins, will be having more hypoglycemic chances when compared to the long-acting basal analogs like Gargin and Altimer. Next is alcohol, hot weather, stress, then exercise, weight loss, AKI, CKD, hepatic diseases. Also, these factors contribute to the hypoglycemia. Elderly patients will have hypoglycemia due to polypharmacy, cognitive impairment, and decrease the renal function. These are the some factors contribute to this thing. So next is how to prevent hypoglycemia. So we can prevent the hypoglycemia by two methods. One is SMBG, self-monitoring blood glucose. Second one is continuous glucose monitoring. So these two are the recent. We can do SMBG at home. We can do CGM in home or office or some places. Next is educate the patient. We have to educate the patient by fasting the blood. Some patients will be fast for more than 8 to 10 hours for blood tests, and some procedures also, some like normal OT procedures or minor table procedures, they will fast for more than 8 to 12 hours, delaying meals during or after the exercises. And we should counsel for the patient for OHS and carbohydrate counseling and physical activity. So there are some studies will be there. These studies will tell about how to prevent the hypoglycemia. All hypoglycemic events should evaluate, and frequency of timing events and timing of the events, current treatment regimens, and severity also should be checked out for the hypoglycemia. Treatment options. So what treatment options will be there? See, first one is pure glucose or fast acting carbohydrates. These are the only drug of choice, oral therapies. So first one is, if the patient is having the hypoglycemia, if he is conscious, you can give glucose or fast acting carbohydrates. Then fast acting oral carbohydrate is what is there? Chewable tablets will be there, oral gels will be there, liquids will be there. Next one is rule of 15. What is rule of 15? If the blood glucose level of the patient is less than 70 milligrams per dl, 15 to 20 grams of glucose can be given. 15 minutes after, recheck the blood glucose. If the patient is okay, take a meal or snack. The meal should be having blended carbohydrates and fats and proteins. The snack will be having jellies, sandwiches, crackers, and granular bar. And if the patient is not improved, recheck, give again the same doses of 15 to 20 grams of glucose and repeat the dose after 15 minutes. Next is 15 M&Ms and Skittles. These are the candy bars. It will be available in the pharmacy, or it will be available in social websites. So some carbohydrate, these things, regular fruit juices, regular soda, 2 tablespoons of raisins, corn soup, table sugar, honey, non-fat milk, candy bar, jelly bars. These jelly beans can increase immediately. The patient is immediately increases the blood glucose level. When in hypoglycemia, patient should avoid high fat and protein content, because these will slow down the absorption of the blood glucose. So hence the patient hypoglycemic event should be prolonged. So what antidote for hypoglycemia? Glucagon is the preferred. Glucagon is the treatment of choice for the hypoglycemia in so many conditions. It can be given IV, IM, subcutaneous, produced by the alpha cells in the pancreas, released when the blood glucose comes to 80 to 90 milligrams, increase the blood glucose and prevents the hypoglycemia. Patient is advised for patient with clinically significant hypoglycemia should be there. When given the glucagon, triggers the adenyl cyclase in the liver, stimulate the conversion of AMP to cyclic AMP. When cyclic AMP increases, it leads to glycogen to break down to rapid acting glucose. This is called as glycogenolysis. and leads to euglycemic state. Depleted, if these things is completely, patient will be having glycogen stores. When the patient is not having glycogen stores properly, like elderly, chronic alcoholics, low body weight patients, there is no response for the glucagon, and in that time we should go for the IV dextrose. For adults and pediatrics more than 20 kgs, 1 milligrams and less than 20 grams, 0.5 milligrams should be given. Where to given? Buttocks, arms and thighs. And in 2020 FDA approved emergency kit, in that it contains 1 gram per vial. IV glucagon increases the blood glucose. After that, once the patient gains consciousness, you advise for the ingest the carbohydrates like fast acting carbohydrates followed by long acting carbohydrates. In that long acting carbohydrates, along with that, proteins and fats also can be given. Then recently FDA approved intranasal glucagon. This one intranasal glucagon is approved, and there is a comparational study for intranasal glucagon versus injectable glucagon. There is transient increase in after 15 minutes of given the injectable glucagon and intranasal glucagon. The injectable glucagon will be having 12 minutes time will be taken to increase the blood glucose, whereas the intranasal glucagon has 15 to 16 minutes. But FDA has been approved Baqsimi 3 grams 15 minutes. Once we have to intranasal glucagon, we have to advise the patients, like patient attenders, caregivers. It should be given with the tip of in that regimen. You should keep that one tip in the intranasally and give one shot. After 15 minutes, you check it out. Again, the patient is having low. Again, you have to repeat the procedure. In 2019, I think in 2019, pre-filled injections like auto injectables will be also approved by the government FDA. If the patient is having more than 45 kgs, 1 milligram, less than 45 kgs, 0.5 milligram, it should be given lower abdomen, outer thigh or outer upper arm. It should be given at around 90 degrees, 5 seconds to hold the patient until the completely that liquid should go inside the body. When you give the intranasal glucagon, you will be having nasal irritation, ocular irritation, head and facial discomfort will be there. But when you give the injectable glucagon, the patient should be turned one side to prevent the vomitings, and also will be having nausea, also will be having. Glucagon will be having positive inotropic effect and chronotropic effect. So patient with cardiovascular defects should monitor for the arrhythmias and hypertension. Because of this, it will be having positive inotropic and chronotropic effects. Contraindicated in pheochromocytoma, insulinoma, glucagonoma, and relatively safe in pregnancy. No dose adjustments in hepatic and renal. And when given with the warfarin, there is increase of the risk of the bleeding. So should monitor for INR and bleeding manifestations. Next is recently approved is 2021 dasiglucagon. This the active formulation will be there. 0.6 milligrams per 0.6 ml. Single dose pre-filled syringe will be there. It is given lower abdomen, thigh and upper arm. Side effects will be nausea, vomiting, headache. Contraindications is like same injectable glucagon. What is the difference between injectable glucagon and dasiglucagon? The recovery time period is injectable glucagon is around 12 minutes, but dasiglucagon is around 10 minutes. This is the only. And in patients with starvation, adrenal insufficiency or chronic hypoglycemia, dasiglucagon is ineffective to improve the hypoglycemic. There is no studies in the pregnancy. When you give with the warfarin, there is an increased bleeding risk. When you give with beta blockers, there is a transient increase in the pulse rate and blood pressure. When you give with indomethacin, there is a loss of ability to increase the blood glucose levels. This is the complete regarding hypoglycemia and hypoglycemia management. Thank you for watching.